This is It's Not In Your Head podcast with Dan and Jez. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Hello, and welcome to another episode of It's Not In Your Head. I'm Justine Feidelston here with Dr. Dan Bates. Hey, Dan.
Hey, how are you?
Good, good. Doing well.
That's not true. You're like in all sorts of pain at the moment, and it's going to be Wiggle Town big time. So
I feel like it's very fitting that we're going over how to draw pain diagrams today. I'm not going to be the only or even the main example. We're going to go through a bunch of different ways that pain presents and how it looks and how, as a patient, you can more effectively communicate what you're experiencing, just like when I get in situations where, is it my leg? Is it my back, right? Is it the CRPS? What underlying or accompanying pathology is ramping things up? And a lot of patients that I work with, if they were to draw a pain diagram, it veers highly sensitized, coloring everything in, really hard to decipher what's what. Other patients, if they draw a pain diagram, you can pretty quickly and easily, if you're Dan, make out what they're presenting with. And as they develop more types of pain and more complicated pathologies, it can be harder to tease apart and from the patient end express and from the physician end decipher what are they presenting with. So from the patient perspective, really what you need to be able to do is communicate what the doctor needs to work out your problem. And what's hard, and I've been guilty of this before too, from the patient point of view, is when you come in, and if you're highly sensitized especially, it's kind of like a word vomit, a lot of, confusing or missing history, and it can be really hard to tease apart what's going on. And so without a pain diagram and being able to tease apart what types of pain are presenting within that really complicated, potentially muddy, overlapping picture, you need to have a better way to express that. And Dan's figured out a really good way to have his patients draw his pain. And to be honest, it's different than how I have ever been asked to draw my pain, for example. And it would have been helpful in some context to be able to tease apart what's neuropathic, what's myofascial, right? What's peripheral sensitization versus something centrally fueled. So like I said, we'll go through a ton of examples, and hopefully it helps you also maybe recognize some of the pathologies or the things that you deal with, or be able to then better, communicate it once you recognize it.
Now, I think I'd love to take credibility for this, but this isn't mine, actually. This is what I got taught. So this is what I got taught from the guys at Metro Pain in Melbourne. They sort of molded and developed the way I approach these things. The thing about this is getting down to what doctors need to know. And I think that you can start to think about it in a couple of different ways. So most of the time when patients present, in part, they need to tell us how bad it has made their life, right, for us to understand the impact on what's happening for them. But unfortunately, how bad it's made life doesn't actually help me diagnose what's causing it. It will actually help me make some decisions around what I'm going to do. But with regards to like how bad it is, doesn't help me with the diagnosis. What I need to know is, where is it? What does it feel like? What's made it worse? And I think this is where we start to get this disconnect between doctors and patients, that he's not listening to me, where we're listening, we just need to listen. We're listening for specific components within it.
And as the patient, sometimes you feel that the doctor has to understand how bad it hurts to help you, but they don't. They need to understand where it is and what it feels like. And it's hard to take that element out of it when you're the one suffering, because you also want that empathy and understanding and feeling like they register that. But it's not the most important thing, and it actually makes it even more confusing to then diagnose in ways. And so as a patient, if you can set that aside and not be frustrated by that, you can quicker get to the bottom of what you really want solved too. So that's the first, miscommunication that can be cleared up.
Now, one of the other things that a pain diagram helps you achieve is it helps people see your pain. So one of the biggest problems with chronic pain is that nobody can see it. And so by being able to draw it, all of a sudden you're able to express, well, this is actually where it is. And with these components, which will teach you, this is actually what I am feeling. And you can do it in a visual fashion. And so your pain goes from being invisible to visible, which is really, really powerful. For me as well, I can't do this job without a pain diagram. Like the way that people describe pain in so many different ways that unless I have a structure and I can see things visually, and that's part of just kind of the way I learn and the way I think, I need to be able to see the pain. But once I can then see it, I can then understand it and move through it really quickly. Yeah. So one of the important things about pain diagrams, and we're talking about in there, if you go to the data, so you go to the literature on this, generally the literature is pretty poor. They're pretty much useless. And there's a...
Which tracks, given how they're often executed.
Yeah. And so...
frustrating.
So what we're going to do is we're going to put up a bunch of different diagrams at the moment that will take you through what is like a group of things that are useless, and then we'll sort of go into how do you draw things that are actually useful that make sense. So I think the first thing, let's draw a couple examples of useless. So
no differentiation.
No differentiation. So basically what do you do? So anyone comes in and does like, gives me a cross over this and a cross
shading
over a shoulder.
The whole thing. Yeah, that's what I've been done.
Isn't useless. I think that a complete circle around an entire limb also is useless. You can just tell me my arm's sore. Other things that are less helpful, not useless, is what Juz just said, which is the scribble, where somebody just comes in and just scribbles over the entire body, and you go, okay, like perfect. Pain everywhere, right? We have to. So I think what I get out of that is that patients probably got fibromyalgia sitting underneath this.
Right.
But within the fibromyalgia, lots of patients will be able to go, actually, no, that's not my fibro. That's my fibro. This is something else. I said, okay, let's draw the something else and we'll tease that out without paying attention to the fibro.
Yeah. And that's very similar with CRPS too, because you have so many other coexisting things and what symptoms are coming from what, and being able from a patient perspective also to be like, what am I tackling now or with this intervention? Because it's not fix everything all over.
Yeah. So I use a key at the bottom of the pain diagram and I'll teach the patient what I would like to do. So what we're doing is we're breaking into different types of pain. So we're going to go achy and broad pain, which is normally nociceptive or broad type pain. We're then getting into neuropathic pain. So sharp pain, which is generally intermittent, pins and needles, and then numbness. Okay. So what I'll ask patients to do is firstly, if they've got achy or broad pain, they just want to scribble over it. For sharp pain, get them to do a little lightning bolt. For pins and needles, we ask patients to do some dots. And then for numbness, just circle the area of numbness. Generally, it takes patients a little bit of time to process that.
Separate it out.
But they then start to work through it.
And that's actually a good thing to think about if you're a patient and you haven't yet. Like, what bucket of symptoms is this broken apart into?
Yeah, and very quickly, what you're going to work out of that is if the patient's got just focal achy pain, it's nociceptive, they got no neuropathic stuff, you've
body
looked at their diagram,
visceral.
Job's done. Yeah, let's go find out what it is and treat it. If they draw area that's widespread, you're going to know that's not particularly anatomical. Okay, you automatically know that this patient's got a degree of sensitization.
Thinking more nociplastic.
Now we're starting to think nociplastic pain, and they'll probably have some pins and needles, numbness, electric shocks in
some
between
neuropathic element.
So so automatically by looking at the diagram, you're then starting to get a decent feel about what's going on for the pain.
And a plain neuropathy, Dan, that would follow a distribution or a pathology.
Right? Neuropathies are the best because patients come in. Yeah, it's the easiest because they'll come in and they'll draw something that's either in the distribution of a nerve or it'll be, a sock or stocking distribution. And you're like, well, that's a peripheral neuropathy.
Neuropathy or CRPS, like it's in one limb and it's very neuropathic. Yeah,
and it's very quickly, and you get to the diagnosis really, really quick. It's then much of the time becomes about confirming that, so just making sure that it's not a bunch of other things, and as you're going through a history, and then it's about what's causing that, which is then the other major question. Yeah. So with the patient that's sensitized, that's drawn over everything, what you then can do is you can add into that something like the central sensitization inventory, which I get patients to fill in before they come into the room. You can add in a measure of their emotional status. So I tend to use a DAS-21 because it gives you a breakdown of depression, anxiety, and stress levels, which can be actually very different between patients. And
Yeah.
so once you've then got a diagram, you've got a central sensitization imagery, which tells you how sensitized the patient is. And you've got how depressed, anxiety, and stress
You have a sense
are.
of their amplifiers too that are adding to it.
You've automatically got this breakdown very, very quickly of what's happening for the patient. And so the way you can put that together is that if you've got a patient that's drawn a focal area of pain and they've got, a CSI that is subclinical, so it's in the 20s, and they're not depressed, anxious, or stressed, well, this is a body part. Like, this is a nociceptive source of pain, and, just go chase it. Alternatively, you've got the patient that's come in, they've colored in everything. And, I would also say that the red pen is a red flag. So if you're a clinician, the patients use the red pen. Like, there's a whole stack of other emotional stuff going in there. It's generally my experience.
I am communicating how severe this situation is. Absolutely. And again, that too is not patient's a baby, patient's over dramatic. It should trigger, whoa, patient's probably sensitized, right? If they're like, this is the worst pain, 10 out of 10, and you're like, it shouldn't be that bad. That's the disconnect.
Yeah. And so then what you've got in that setting, yes, it's disproportionate pain. So you don't see much on scan, but it's disproportionate. Patient is
and their DAS 21 and their CSI should be high.
Probably going to be high. Yeah. And so it then starts giving you that, okay, we've now more got a sensitized patient. We now then need to start breaking that down into components, which if you've looked at the last episode, you can see how you can break it down into 7 different components and start splitting it up to treat it. So,
right.
So over the years, a bunch of doctors/scientists have tortured a bunch of med students. And what they do is they inject stuff that hurts into joints or discs or in nerves, and they see where the pain goes. And so over many years, this has been done. I don't think it's done anymore because you're not allowed to torture the med students.
It's frowned upon.
Yeah, it's frowned upon. But what they do, what it's done is it's generated a set of diagrams of which you can then say, this is where an L4-5 facet joint sends pain. This is where a L3 disc sends pain. This is where a hip sends pain. And so what we'll do is you can see the diagram that's here. This diagram is the diagram for the majority of lower back pain. And so lower back pain has 5 major causes. So that's facet joint, sacroiliac joint, hips, discs, and nerves. And how we split it up, if it's worse in your legs than your back, you start at nerves first. If it's worse in your back, you start at your back. What I then do, or what we then do, is you split your back up. So it's above the belt line, you start at facet joint and disc. If it's below the belt line, you look at sacroiliac joint and hips. So they are rules of thumb. They give you a guideline of where to start, not this is definitively the diagnosis. Now, that said, they're pretty good guidelines. So Jazz is doing Wiggle Town and standing up. It's desk going up in the background.
On brand for the episode, just slipped my right SIJ little.
Yeah, nice. All right. So what you can see in the middle here is you can see this is where traditionally discs will refer pain. So a lot of the time they're central and they radiate down over the buttock and then down the back of the leg. So facet joints will go from across lower back and then down over the buttock. Sacroiliac joints start below the belt line, have a focal area over the buttock, and then go down into posterior and lateral thigh, and then calf, and then lateral foot. Now, that distribution is the same as an S1 nerve root distribution. So they overlap, and so they can become essentially they're differential diagnoses for each other. And they both give pain into the same area. Hips are interesting. Hips will give you pain that radiates, comes down the front of your thigh and the back of your thigh. And interesting, if you look right down the bottom of the diagram, they'll even go to the ball of your foot, which is like weird.
Yeah.
You don't see it that often, but I have had like a number of patients do that. And then the last piece is then nerves. So there's a couple of diagrams here we'll show you. This first diagram is what essentially the Italians drew however many hundreds of years ago that kind of looks like this perfect thing. It's not like that at all. These other diagrams show areas where you get dominant pain. So for a For an S1 nerve root, S1 nerve roots will give you pain dominantly to the outside part of your calf and then outside part of your foot. For an L5, it will dominantly, once again, outside part of your calf, top of your foot and your big toe. Interestingly, S1 will generally go to the sole of your foot as well. L4 nerve roots goes to your shin and will go more across the anterior part of the front of your thigh.
Yeah.
And L3 comes down across the thigh, gives you a lot of lower back stuff, actually. So lower back, thigh, and then down onto the inside part of your knee. And you can see this diagram gives you these, let's call them hot spots for where nerve pain goes. And I think this is a really good representation of it. So I think that's pretty accurate.
If you have something like a spinal cord stimulator, right, this is what they're basically following to sort of place that lead and cover the swatch of your body that's most symptomatic. Yeah. So for me, right, L4, S1 is where my leads were placed to cover knee down, kind of calf, anterior part of my leg, foot as much as possible. So if you have an injury, same pattern, it's going to kind of follow.
Yeah, which is, and when that happens, that's awesome. Unfortunately, as our body is very plastic, you get rewiring and you get rewiring of, I have a patient at the moment we did some sensory nerve testing recently, and they were getting sensation into their big toe off S4, which I didn't expect.
Shouldn't.
So, and I would have said shouldn't take place, and I couldn't reproduce his normal pain with the nerve roots that we would have expected. So he's had some rewiring take place. So we just need to go and look. And that situation is very common, particularly with people who have had like an entire limb injury where you get a lot of rewiring that takes place at the spinal cord level. So that's a little bit more complicated, unfortunately. But if it wasn't complicated, we wouldn't be here. So, there you go.
We wouldn't have a podcast.
We wouldn't have a podcast, and
everybody would be fine.
And 20% of the world wouldn't have chronic pain. So
because you can see how many of these pathologies, injuries, just things accumulate and simultaneously are going on, even if someone isn't highly sensitized. And if you can't tease it out, it's hard to treat.
Yeah. And so the last point about like this set of diagrams, and we'll give you a set of diagrams that we'll show you for neck as well, that you'll be able to get off the website. The important thing is that they all overlap. Just because it looks like a facet or it looks like a disc or it looks like, doesn't actually mean it's going to be that. They are all differentials of each other, and it's a matter of starting at, well, this is most likely, and you work your way through until it's least likely. How we do that with the diagnostic block approach. So I think this is facet. I'm going to do what's called medial branch blocks. We'll test whether the pain goes away. If it doesn't, okay, I'll go on to my next most likely.
Yeah, that's one procedure I had done, highly sensitized, 6 medial branch blocks at once. It sucked.
Yeah. Oh, yeah. And it's interesting, okay, so this is the difference between US and Australia. In the US, there is no anesthetic item number for medial branch block. So the reason why they're done unsedated in the US, regardless of how much your back hurts, is because there's no way to actually pay the anaesthetist.
Oh, it didn't even occur to me.
In Australia, that's the, and in Australia, you can use an anesthetic item number. So for me, we do a lot of stuff anesthetized, and you can then get into the argument about, how that affects the block. And my general rules are that if I'm doing an injection through the area of pain, I'd like the patient to be anesthetized. Because if you've got 8 out of 10 pain and I'm about to stick a needle through your 8 out of 10 pain, guess what? It's going to hurt. If I'm going to do an injection for let's say it's your leg pain, but I'm targeting your back and you don't really have any back problems going on, so I can I'm happy to do your back unsedated if you're not sensitized. If you're sensitized,
you're not going into the painful area to do the procedure.
Yeah. And if the patient is sensitized, so let's say that I've done a central sensitization inventory on them, their number's getting over 60, so they're in their extreme range. That means that a 25 gauge needle hurts a lot more on that patient than a 25 gauge needle does on me, who's not sensitized. And what happens with those patients is that they're so sensitized, it's the needle and the sensitization, they blow up in a big ball of pain afterwards. And it's not to do with the technique. It's got to do with how sensitized the nervous system is. And it's in those patients I would really we want them to sleep.
To bring that down first.
To minimize that as much as we possibly can. So
and even outside of the pain perspective, what makes it hard then if you do a procedure like that going into the sensitized area on a patient is I basically could not well evaluate how effective were the blocks even, because you're feeling different types of pain, heightened sensation from, the neuropathic stuff that's now revved up, but it's different than the myofascial pain that you kind of went in there for trying to address. And then you're trying to tease out how much did affect the pain that I went in there with versus how like blown up am I and I can't even tell it apart. So yeah, it makes it hard.
But it is hard. So let's move on and let's talk about how do we draw backs. So just let's go through. So 5 major causes. What do you want us to draw first?
All right, let's start with facet.
Okay, so facet joint pain is a body part, so it's nociceptive. It tends to be focal and it tends to be intermittent, has specific things that make it better and worse. So, traditionally, patient with facet joint pain is worse with bending backwards, worse on what's called quadrant test, where you sort of get someone bend back to the side. Patient's back is worse than leg, and it tends to be focal. So most patients are going to draw something that is, like that. So it's above their belt line. So I will then ask the patient how big is the area. So you're looking for golf ball, tennis ball, mango, football size. And with a facet, it's probably going to be unilateral. So for those who are watching, you can see the picture in the middle that shows, it's above their belt line, tends to be focal and tennis ball in size. Now, it can radiate down the back of their leg. It tends to be achy. It tends to not be sharp, but it is not sciatica. So sciatica is not just pain that rates down the back of your leg, which I'll rant about in just a moment.
Yeah, just a separate soapbox on sciatica.
Yeah. So
SI joint?
SI joint. So SI joint will present in 3 components. So there's 3 major causes of sacral joint pain. So there is inflammatory disorders. So your rheumatoid arthritis, your psoriatic arthritis, etc. There is SI arthritis, so osteoarthritis of the joint. And then the third component is sacral joint dysfunction. And they all look slightly different. So SI joint will present initially with pain below the belt line, and the inflammatory patient will draw something that's about tennis ball in size. And so how we try and split this up for patients and get them to do it accurately is I'll ask the patient to draw their pain, and then I get them to stand up and then point to their pain for me. And so
confirm it.
Yeah, and confirm it. Because I think that's one of the things that you look at the data, most people don't have good body position sense, so that when they're drawing
it's a brain mapping issue when you don't feel well.
Yeah, so as a clinician, the piece you have to do is go, okay, draw your pain for me. Great. Okay, now I want you to point to it. And so by then pointing to it, you then get a better understanding. So inflammatory stuff will tend to be relatively focal, tennis ballish in size. It'll be over the sacral joint. I'll ask the patient to point at it, or if you're doing it by yourself and you're the patient, what you can do is put your hands on your hips, and if your pain's below where your thumbs hit is, you're then starting to look at sacral joints at that level. For the arthritic joint, what ends up happening is it tends to be golf ball in size.
Even smaller.
So they'll come in and they'll go, oh, my pain is it's even smaller.
This spot.
And the general description will be, get this, it's achy across here, but I've got this main area. And I'll ask the patient, this is my tricky question, which is, hey, can you point to your pain with one finger? So that's called, and if they can, that's called Fontaine side. And so that increases the likelihood that it's going to be sacral joint. If they can't point to it, what they do is they kind of lose like 3 fingers. They'll go, if they can do it, they point at it, and they go, if it's bigger than like golf ball, they'll go, it's in about this area with 3 fingers. Like, it's pretty reliable how everybody does it.
That's funny.
So then what patients will present with is if you've got sacral joint dysfunction. So SIJ dysfunction is where what you see is the sacral joints are moving. And so normally they will move only a small degree, about 1 to 4 degrees. If they move more than that, what ends up happening is you start getting muscle spasm around it, and patients will start to draw the muscle spasm. So what you'll see is that it goes from being unilateral to bilateral. And so they'll have a focal area, but then they'll draw it so that they get spasm of glute medius, which is
because it starts to cover your whole lumbar.
which is one of the muscles that sits across your buttock, and then it goes to your lateral, out to your lateral thighs. And so most people with sacroiliac joint dysfunction, what they're doing is that as they walk, they wobble. And you then have a set of muscles that then are trying to stabilize you. And the muscles that do it for most people, particularly females over 40, is glute med, and that then gives you lateral hip pain. Now,
overworked and underpaid.
Yes,
and they don't want to lengthen, so it's like this, holding on for dear life. Yeah.
So this gives you this broad pain that sits across the outside. Now, most people will get diagnosed with trochanteric bursitis. So I've got a bursitis on my hip. So the bursa is collateral damage in this setting. So what you've got is you've got the underlying tendon problem. The bursa is trying to protect the tendon, and so it gets inflamed. And the reason why you get labeled with trochanteric bursitis is because that's the thing we can see on ultrasound most easily.
On a scan, right?
Yeah. And so everyone goes on to get injected with 1 million cortisones, which work transiently, and then it stops. And then they stop working and they still got pain. So the issue really is the underlying sacroiliac joint. Sacroiliac joint dysfunction. What patients will also draw with SIJ dysfunction is then overactive psoas. So psoas is a muscle that sits at the front of your hip, and so it causes groin pain. And so what patients end up drawing looks like a bilateral groin pain, because psoas has gone from being a flexor to it being a stabilizer. And so it's turned on all the time.
All the time. Yeah.
And it does not like being turned on all the time.
Right.
Yeah. The last piece within sacroiliac joint dysfunction is if you have pubic symphysis dysfunction. So your pubic symphysis is the joint at the front of your pelvis. And when that's moving, what ends up taking place is your lower abdomen then starts to spasm to try and stabilize that area. So the last piece people then draw in is pain across the front of their pubic symphysis. So they get this
like almost transverse abdominis kind of.
It is. Lower, so it's lower abdo is then turning on to stabilize pubic symphysis. They got psoas turning on to stabilize sacroiliac joints. And you've got glute med being like doing laterally, and then you've got the pain directly from the sacroiliac joint. And so that is a very, very, like, people will draw that again and again and again. It is
and hypermobile people will draw that again and again and again. I mean,
So that's SIJ dysfunction. Nerve pain is then the last bit. And so what people do is that's when we're starting to see people draw their pins and needles and their numbness. And so what they'll do is if they've got a S1 nerve root compression, they'll draw commonly an electric shock with some aching over the calf and pins and needles through that same area, but it'll be over the outside part of the foot. And so then you're very quickly going, okay, this is going to be an S1 nerve root. L5 follows a similar pattern. So they'll go over their buttock, lateral thigh, lateral calf, but it'll then involve the big toe. And they may have pins and needles over the top of the foot more dominantly, and pain into the big toe. So I'll be always looking to say, hey, where does it, you got pains going down your legs, does it go into your foot? Yes. It goes into your foot. It's a big toe or little toe.
Which part?
Which bits? Because if you can get that clear-cut delineation, which you can a lot of the time you can't, but a lot of the time you can. Try. That gives you, like, you're then starting to hunt down where this is coming from very quickly. L4 is different. L4 comes across the lower back, and then it will come across anterior thigh and into the medial part of your cuff, so into your shin. That is pretty reliable. The last one that is most common is L3. L3 nerve root compression gives you quite a large amount of back pain and then wraps around the front of the thigh and down into the medial knee. So the inside part of your knee is where you'll get L3. And people then describe into that area, they get numbness across the front part of their thigh, and they'll get intermittent pins and needles. And so very quickly, if you've had the patient come in, they'll go, okay, just draw where your pain is. They'll go, oh, it's sharp through here. I got pins and needles, and I've got numbness through this area, anterior thigh. Like, you're very quickly going to go look at the MRI and have a look whether they've got an L3 nerve root compression.
Yeah, so very different presentations, right, based upon which part of somebody's back, even, for example, is affected.
Yeah. So let's go on to talk briefly about necks. So neck pain there's 4 major components to neck pain. So first component is, there's facet joints, nerve, disc, and in my population, cervical instability. So neck instability, which is a controversial diagnosis, but has quite a specific presentation that's worthwhile drawing because if you listen for it, you can find it, and it produces a whole.
It's so common in EDS.
Yeah, it's common in EDS, and it produces a bunch of really weird symptoms that are hard.
And if you miss it for years and years, it's really tough from the patient perspective.
The way I tease apart neck pain is to basically look for pain that is worse in the arms, so essentially shoulder blade and below. If that's where it is, I'll start at nerves. If it's worse in the neck, so shoulder blade and above, I'll start at, you want to then ask the next question, is it bilateral? Is it unilateral? If it's unilateral, you start at facet. If it's bilateral, is it focal or is it diffuse? Okay, so if it's focal, once again, you're going back to start at facet. But if it's diffuse, you're looking at 2 things. Is it disc or is it cervical instability? We'll draw each one of those things. So let's start with the patient that has got pain below, like shoulder blade and below, and show where that will go. So shoulder blade and below is nerve pain. Now, one of the things that's really important to understand is that your nerve roots, C4, 5, 6, 7, and 8, all give you pain between your shoulder blade.
Between shoulder blades.
Yeah. So they'll give you, and I'm just drawing it at the moment, so drawing in between the shoulder blades, that is nerve root pain. And what is it? It feels like this tightness, and it probably is muscle spasm in that area.
Eventually develop,
due to nerve root compression. And then as it goes down into your arm, it'll go down into different areas. So C4 is dominantly to shoulder, and C4 will also wrap forward over the clavicle, which you don't see super often, but you see it enough that it's common.
Oh God, thoracic outlet is just such a nightmare to think of.
We'll talk about thoracic
Neuropathic
some other time.
Not today.
For C5, it'll go down to the elbow is the main area with radiation down the forearm. So they'll go down the elbow and into the forearm, and you might get, but not really extending into the hand. And patients will generally have a dominantly achy forearm. For C6, they also get the shoulder blade pain, but this will then go down to forearm and into the thumb. And commonly when patients will say, I've just got pins and needles into my thumb, that is very much a C6 nerve root compression and makes life, easier. Numbness into that area as well is really useful. C7, once again, gives you pain between the shoulder blades and then down your arm and dominantly into your middle finger. So your middle finger will give you the numbness. Patients will also get numbness and tingling into their index finger, which is what I've got because I've got a C7 nerve root compression. And so you get pain and numbness into dominantly these 2 fingers and the medial part of that, which is your ring finger being the dominant component. The last component is then C8, which comes down and into the outside part of your 4th and 5th digits. Now, your 4th and 5th digits will also get involved with shoulder pain. So nearly everybody that's got a shoulder pain source of thing will also have pins and needles that are chucking down into their fingers. And your ulnar nerve, which comes down the outside part of your arm and down to you, will also give you pain into that area. But C8 is the nerve root that will give you that area of pain. The next major thing within necks is then facet joint pain. So we'll put up the diagram. So there's a diagram that was done numerous years ago, once again, probably torturing a bunch of med students, that shows where each one of the facets will send pain. Now, this diagram is, surprisingly very, very reliable. The other thing about it is, although a lot of it overlaps, many patients will just have one or two facet joints that are painful. So we'll go through from C1, 2, which is your atlantoaxial joint. And so that will give you focal pain right at the top of your head. So just below your occiput, which is the back part of the bony part of your head.
Right
and you most commonly see that in older patients because it's where people are developing osteoarthritis with it. C2, 3 is the next joint below. So that will give you pain that extends up behind the back of your head. It gives you pain most notably when you rotate your head, and it's probably the joint most commonly that gives you pain that radiates forward, gives you pain behind your eye, and it's most associated with giving people headaches. So for people that get neck-related headaches, it's normally a C2, 3 joint. That's supplied by a single nerve known as the third occipital nerve. C3, 4 gives you pain the next level down. So the way I think about it is if you take 3 fingers and you put them over the middle of your neck, that's pretty much the distribution of the C3, 4 facet. The C4, 5 facet extends a little bit further down, just to the top part where the angle of your neck starts to track out into your shoulder. So C4, 5 is out in that direction. And C5, 6, which if you're watching, you can see me draw all of these as we go, will track down out over trapezius in this big triangle type area, and that will give you C5, 6. So if you've got pain that's coming down out over here that's related to your neck, that'll be C5, 6. And just to complicate things, because we can't keep it simple, C6, 7 comes down over your scapula. So, which is unfortunately where it sends all our nerve root pain. But it's less common as a source of pain from the neck. So C5, 6 is far more common. I would say that nerve root compression is far more common than C6, 7 facet joint arthritis, at least in my practice. One of the important things that I'll draw next is whiplash injury. So when you have a whiplash injury, what you're injuring most commonly is your C2, 3 and your 5, 6 facet joint. So you get the combined. So you get C2, 3 picture at the top and the C5, 6 picture across. So what you end up doing is getting this pain that extends from, just above your occiput and then down and across the entirety of your trapezius.
So we've talked about neuropathic pain in the setting of back pain and neck pain with different nerve root examples that we've taken you through. Now we're going to get into a couple different pathologies related to neuropathic pain and how those present from a drawing perspective on the pain diagram. You want to walk us through a couple of those?
Yeah, there's a bazillion different examples, but we're going to use just a couple of examples. So firstly, just a focal nerve entrapment. So focal nerve entrapment, like superficial peroneal nerve. So the superficial peroneal nerve extends down over your last 10 centimeters of your ankle on the outside and then down into the lateral part and top of your foot. When you draw it, it is very specific and it's commonly injured after a ankle sprain. So for patients that have a severe ankle sprain that have ongoing nerve pain in the lateral aspect of their foot, so it might be burning, pins and needles, numbness, itching, crawling, painful cold, you can map it out and just draw it. And so just asking patients to draw it, it's simple. And I remember an old chap that was really struggling with his pain. Nobody had asked him to draw his pain. I just went dude, just draw it for us. And he drew it. I was like, well, it's superficial peroneal nerve entrapment. And as soon as you draw this stuff, easy to see. You take it from invisible to visible. Beautiful. Patients will also present with, new onset diabetic peripheral neuropathy. So something like peripheral neuropathies present differently. So they will present not so much in the distribution of the nerve root or the plexus or something. They will present in what we call a glove and stocking distribution. So if you ask them to draw it, what they draw, if we're talking commonly diabetic peripheral neuropathy. It will present with feet first. They'll draw essentially long socks. So long socks that pull up over your ankles to mid or just above mid calf. They'll draw that, and it's very obvious, and they'll done. That's, commonly a peripheral neuropathy. The question then is, which one of your diagnoses is actually causing it?
Right. What's driving the neuropathy?
Yeah. One thing that we haven't talked about in this setting is myofascial trigger points. Trigger points will radiate pain into multiple different areas. They tend to be relatively specific. And of course, as a result, they overlap with a lot of other diagnoses. For me, myofascial trigger points are commonly a secondary condition, although not necessarily all the time, but most commonly it's due to something else underlying.
And it's the body's response to trying to create more stability, right?
Yeah, that's my take on it. There's a couple of pictures. So Travell and Simons, they are that's the book that is the Bible of myofascial trigger points. You can see the little dot of it up in the right-hand corner. So it's the Bible. We'll show a couple of pictures out of that. And, trigger points, I find it very important around shoulders, particularly infraspinatus trigger points when you've got essentially a shoulder that's moving pretty well. You can't find any specific other issues, but you can stick your thumb into the myofascial trigger points and it will refer over the front. It'll come down their arms and it can give you pins and needles and weird stuff as well. So in the right setting, they can be perfect to treat, but we haven't covered them in detail here because there's a million of them.
But they're important to take into account because very similarly as with sensitization, right? It's a secondary sort of downstream, you could say, response to the underlying issue. And then those symptoms, right, if you don't have a way to tease apart what feels like neuropathic versus what feels like myofascial, the patient's just shading all the same area in. And a lot of that is myofascial trigger point response to the actual problem, not the problem itself. And so if you can't tease that apart, you can't see those pieces separately. And it's very common. I mean, it's a big part of pain.
The last bit is when a patient will present with multiple diagnoses in one pain diagram. And so I've got two examples. So the first example is a patient that is presented with 3 separate diagnoses. So when I first looked at this diagram, I was like, I don't know what this is. And so for those, obviously listening, what this patient has drawn is she's drawn a broad area over her right sacroiliac joint that also extends up above her belt line. She's drawn a sharp pain that comes down over her lateral hip across the front of her thigh and then down into the front of her shin, so medial shin. And then she's drawn a third pain that is over the anterior aspect of her abdominal wall, down in that right lower quadrant. So there's sort of just right lower quadrant where you get, traditional appendix pain. And so what this ended up, I struggled with this, but what this ended up being is 3 separate diagnoses. And I just went with, okay, I'm going to treat the thing that I think is, the most likely diagnosis for the stuff over a sacroiliac joint. She was young, she's hypermobile, she's got sacroiliac joint dysfunction. So we treated that. That then went away. The next dominant pain became the pain coming down over the anterior thigh and into the shin. And when I re-looked at it, I realized that, this is radicular pain. And so she had pins and needles down into the anterior shin, and we went on and performed an L4 transfemoral epidural, so an epidural around the L4 nerve root, and we did some pulsed radiofrequency over that nerve root, dorsal root ganglion, and that pain went away. And then we got left with this pain at the front of her abdomen, which ends up being really quite focal. Say it was about, we'll call it 8 centimeters by probably 12. She had allodynia in the area, and this interestingly ended up being anterior cutaneous nerve entrapment. And so we're just in the process of treating that. And one of my colleagues picked the anterior cutaneous nerve entrapment, and as part of one of his reviews, he was managing oral medications. I was like, wow, that's exactly what it is. And so we're in the process of treating all that now. But what was fascinating, I thought, is this in her original pain diagram? I went back to it and it's all there.
Yeah. But there's all the other stuff too.
It was all the other stuff. It was just, at that point in time, it was very difficult to go, this is one diagnosis, which it wasn't, and it ended up being 3.
Right.
The other person I've had recently as well presented with drawing pain down the front of their hip and also pain down the back. Now, I can't take credit for this. One of my colleagues, Bruce Mitchell, worked it out previously. So I just got to take the glory and just redo his work. But this patient had presented with hip osteoarthritis. So if you look at it, the pain down the front is the hip joint, and we treated that with some articular branch injections of the femoral and obturator nerves. And so they're the nerves that we do radiofrequency across these days. And she also had an S1 nerve root compression, which was giving her the pain down the back of the leg and then out into her outside foot. But when she drew it, it's her entire leg. But what's actually taking place is the front part is her hip and the back part is the S1 nerve root compression. And so Bruce worked his way through that, worked it out. She was good for a couple of years. She's come back with the similar pain.
Presentation, yeah.
Same presentation. So I just, instead of doing one, I just injected both and pain settled again.
Yeah. And I mean, in a lot of populations, think about our whole conversation with sensitization, that's unfortunately the norm. Rarely with the folks that I work with do you get just one presentation. And it's even challenging when you're trying to tease apart neuropathy versus some of the central sensitization related sensitizations that can, like allodynia is not unique to CRPS, but the symptoms are very similar to what someone experiences with some of those other elements. And so, yeah, it's nice if you just have one thing that you can nail, but I would think it's very common to have multiple things that, again, goes back to why it's been really important to be able to draw the different types of pain a little differently so the doctor can tease out that person.
And it becomes interesting when you ask the patient to redraw their pain, because once you've treated something and they'll come back and where the conversation will start will be, oh yeah, my pain's still 8 out of 10. Okay.
Right.
Just can you draw for me again now? Okay, what's happened to all the
stuff on your foot's gone.
Right. Yeah, what's happened to all the stuff at the front? Oh, that's all gone. No, that's great. The stuff at the back's 8 out of 10.
But that still hurts.
All right.
So
and what ends up happening is because you've taken away one pain, it takes out a certain amount of the amplification that's affecting the other pain. And so as a result, it actually will map out a lot of the time into what looks like another diagnosis, which effectively is what happened for this patient. And Bruce worked his way through it and she went very well. So hopefully my work can be as good as his for the same patient. So.
Yeah, you're just shrinking it down further and further. And it is easy as a patient to sometimes forget the part that improved because you're focused on what you still have to improve, right? But that too is a mindset piece of if you can at least stop and appreciate, whoa, right? I am making progress, even though this part is still an 8 out of 10. It's not where you were before. And you just keep whittling it down and making the picture clearer and clearer so that you have a smaller and smaller, ball of paint at the very end of everything, ideally.
Yeah.
So,
and from a doctor perspective, we like to hear that you're getting better because if it's always not better,
just gets more frustrating.
It gets harder and harder and harder where we do need to tease out this, this process that we're taking is actually improving this symptom, even if what's left remains intrusive. Great. That's, not great, but you're getting somewhere.
Yes, 100%.
We like to see you get better too. So
we like
progress.
Please
tell us when you do. We like progress. The final one is then cervical instability. Now, I see this because this is the patient group. I would say that it's not necessarily super common. No, and it's certainly a controversial diagnosis. Now, it's not traditional cervical instability from the perspective of you're seeing 3-4 millimeters of movement of vertebra on each other. But what patients present with is they present with pain that extends bilaterally and extends down over both trapezius. And it's in they pretty much color in trapezius effectively in the upper area. And the reason why it's happening is that patients present with pain across that very broad area, but they have the sensation that their head is very heavy, that their symptoms get worse during the day. And for the patients that are really unstable, they describe themselves as having a bobblehead. And so they feel like their head's going to
I
fall
get this
off.
from patients too, like a pin, like a head on a pin, kind of.
And then as it gets worse and starts to progress, the symptoms get more neurological, and they get harder and harder and harder
To treat.
Really to treat. Yeah, it's a very, very debilitating type condition.
Yeah.
All right, just to recap. So as a patient, what you're wanting to do here is you want to take your pain that is invisible and make it visible, okay? And you need to do that by drawing it. And you need me to make the drawing useful.
Meaningful.
So how you make the drawing useful for the doctor is you need to have a key. And so if you've got a key, you basically start with, so if it's achy or broad pain, scribble over it, just a little scribble. If you've got sharp pain, do this lightning bolt. If you've got pins and needles, do pins and needles over the area. And if you've got numbness, then just circle the area. And if you're able to get that as specific as possible, that automatically gives the doctor like a ton of information.
Yeah.
And what's happened for you is, your invisible pain has become visible, and it becomes much easier to be able to explain it to people and people to be able to see what's going on for you, rather than having to use a set of words that are really difficult to explain.
Yeah. Yeah. And with a lot of overlapping, right, symptoms, and just like patients grow to be able to pull out the different types of pain and what certain symptoms feel like compared to others in different areas. And if patients and physicians can get on the same page with that, then it makes the physician a lot more efficient in how they narrow that down, right? Rather than losing time, patient's frustrated, patient doesn't feel heard. And so if you can, from a patient perspective, come into it with this mindset of, ooh, I'm going to go into this appointment and communicate the hell out of my different types of pain, instead of thinking that the goal of the appointment is to get the physician to understand how bad you hurt, because that's not unimportant, but this is the really important stuff. And then given that, you're probably sensitized, or why is it, what's amplifying it? So this gives the patient power, and it gives the physician a roadmap to actually tease all this apart.
And what will happen over time is that you'll also find that things get smaller. So
you can shrink it down.
Yeah, as your pain shrinks down, you'll be able to draw it. It's smaller.
Draw it differently over the appointments.
Yeah. There's a lot of value in using a pain diagram, using it
and you can see your progress
effectively,
which is neat as a patient, because it's such a, it is such a long process, and there is so much involved in it that sometimes it can be hard to very clearly see, wow, I have come really far despite maybe the level of symptoms I'm still dealing with, or man, this area still is really intrusive, but wow, it's so much better than when this whole swatch in my body was, bothering me on a way more intrusive level. And so having those things to compare, just like with other aspects of your own progress as a patient, helps you see that I am impacting this, right? And it is a long journey, but you just keep checking off the pieces that you can and get it smaller and smaller. So
what we'll do is we'll tie this together with how you use essential sensitization inventory and a measure of emotion status. We'll also describe a thing called the bodily distress syndrome checklist, and we're going to show how we draw them all together. That allows you then to define how sensitized the patient is. What are the components of their sensitization?
Right, which we did last time.
Yeah, which then allows people to then have a pathway of things to then start targeting. The pain diagram gives patients what is probably driving this pain, and the BDS, the CSI, and the DAS-21 gives clinicians what's amplifying this pain. And so that's where we want to go.
It all ties into kind of if you're a clinician, like the assessment aspect of things, and from a patient perspective, kind of the goal setting track of how do I approach this. So that's what we'll dive into in coming episodes, is how do you then work through the different types of pain? How do you communicate it? And how do you start to treat the components depending on how sensitized are you, right? What are your nociceptive drivers? What are your neuropathic elements? And then off you go. We appreciate you listening. Thanks a lot.
All right.
Thanks, Dan.
Bye-bye. Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.